question for you is, what is your daily practice? So when do you use immunotherapy in EGFR? If you do your tests, and which kind of neoadjuvant do you do in the clinical practice beside the data? So I would ask a very, concrete question.
Maybe I'll go first because it is a question that I referred here. It's pretty special in our center because I think it's a unique center in China that the medical oncologists like me work routinely together with the surgeons. So first of all, we follow the guidelines for those patients. Most of them, I presented here, these two cases are really special ones. Most of them we will follow the guideline, what the guideline told us to do in a neoadjuvant setting. This is the first way. And the second way for these two patients, it's...
No, what do the guidelines say? Marina may not know our guideline. What the guidelines say? What would you do? Spell out clearly.
Okay. I need to say for these two cases, which was primarily diagnosed as the unresectable stage 3 non-small cell lung cancer, the guideline most of the time will say that follow the MDT suggestion. So for these two patients, we actually followed the MDT. We treat them after a detailed discussion with the MDT team.
So what do you mean MDT suggestion? Get everybody together, some medical oncology, surgical oncology. We still need to have the suggestion go to the new drug, MDT. Is that a clinical trial? I think MDT was a recommended clinical trial, is that right? MDT will not recommend something. But anyway, I'm tough on you. So you MDT suggestion to go to these two drug, to new drug because the patient has the drug, or is there some, is there any conflict of interest? No, we don't go there. No worry. So, okay, MDT suggestion for this one. But for majority of patient, our question is, what would you do for majority of this patient?
Follow the I have presented here for all those neoadjuvant treatment trials. Immunocheck ICI plus chemotherapy will be the suggestion for most of the patients. It's a guideline suggested. After we got all those positive data from like the checkmate, all those checkmate series of clinical trials, whatever, for those first...
Now, may I ask for specifically one of the case you have, N3 disease, the N3 disease with superclinical lymph nodes, left or right lower lung cancer. This patient, the one you presented, it's an unusual case, but usually, what kind of treatment would you recommend in your clinic? Yeah. 皮是怎么做？这样的病人。
I'd like to just say that we will follow the Pacific style because it was what the guidelines suggested.
Good. That's what we normally do. How about the other people? I say Dr. Zhang Yongchang. What would you do? N3 disease? What would you do?
Yes. First, I want to say what does the guideline tell us to do? The guideline tells that you should treat the patient with chemotherapy and chemo and the radiotherapy, followed by the PD-L1 antibody as a maintenance therapy. That's guideline to us to do. But however, we have some, some proof of concept trials, such as Professor Yilong Wu has just published in Cancer Cells, and we have published one paper in the Med. But for me, I would like to say that I would suggest the patient to perform the induction chemo plus immunotherapy as a first line. And if the patient has maybe a good response without the lymph site, then we can perform the surgery.
So you recommend guideline because you recommend the immune chemo immune based on Shitong study. It's a phase 2 study, is that right?
Yes.
Phase 2 study, and is it randomized?
Yes, Professor Wu just published the paper with the phase 2
Okay.
study and
Tell us-
randomized, but for limited sample size.
For limited samples are randomized. It's
Yes.
superior comparing control arm. Control
Yes.
arm.
Compare with the standard therapy.
Standard chemo RT, no
Yes.
surgery. And superiority is, and this is superior. Okay, well, that study, actually, I did not know about that study. Can the Shitong, what's the number?
It's
I
a
mean, the
12.
total number was 107, but they selected the biospecific antibody instead of
Okay.
the PD-1, yes.
Okay, this is a good justification. If you have a phase 2 study to support you, if you don't have a strong study, the guideline is vague, or guidelines say something, you don't have, you have some evidence you can argue. Okay, that's good. Dr. Marina, what do you do? N3?
I go with the neoadjuvant chemoimmunotherapy. And
What's your evidence?
Yeah, it's a zero, my evidence. It's just that I pray that it will work. I think that, as she said, we also discuss in the multidisciplinary tumor board what to do.
Okay.
If it is an actionable alterations, we avoid to give immunotherapy. If it is just a missense alteration, we go with immunotherapy. And for alterations like MET14 or BRAF, we always go with immunotherapy. I don't know if this is correct or not, but this is what we do.
All right.